Complications during pregnancy are diabetes, metabolism is our concept, diabetes is our exemplar. So you can have type 1 or type 2 pre-pregnancy. If you have type 1, you're not going to get type 2, you're not going to get gestational diabetes. You're coming to the pregnancy with your, issues with insulin production already. Gestational diabetes is characterized as an impairment in carbohydrate metabolism that first manifests in pregnancy. So you want to know the difference between the three. Gestational diabetes is similar to type 2, as in it's because of insulin resistance. So most often in the second half of pregnancy, there's greater insulin resistance caused by that heightened production of HPL, which we've talked about, cortisol, and growth hormone. So HPL, again, is that human placental lactogen. And if the mother's pancreas can't meet that increased need for insulin, there's an altered carbohydrate metabolism, and hyperglycemia can result. So what happens with the fetus is the fetus removes glucose from the maternal circulation because glucose easily crosses the placenta. Insulin doesn't. So insulin doesn't cross, so the fetus increases their insulin production, and fetal hyperinsulinemia acts as a growth hormone. So that's why you get those big fat babies, which can also, because of the issues with glucose, that can decrease surfactant production. So you need surfactant, for the lungs, for healthy, respiratory system. So you have these big fat babies, but they have decreased surfactant production. So they're acting like preemies, but they weigh 9 or 10 pounds. So it's important to know the complications for, what can happen to mom and what can happen to baby. Most women will get a glucose tolerance test at about 24 to 28 weeks. There's a 50-gram solution of glucose. If her levels are 130 to 140, usually she'll get a 3-hour test. So that test is a 1-hour test. If her levels are 130 to 140, she'll get a 3-hour test. She'll get 100 grams of a glucose solution. They'll take her fasting level. They'll take her level at 1 hour, 2 hours, and 3 hours. If any one of those, or any two of those, are above the normal, she'll be diagnosed with gestational diabetes and then watched throughout. These women get dietary and nutritional counseling. They also want to see them sooner after the infant is born. Most women get the glucose tolerance screening at about 24 to 28 weeks, unless they're already high risk or they've had gestational diabetes in a previous pregnancy. So you still want to educate mom, on maintaining her blood glucose levels. Diet and exercise are really her first lines of defense. Insulin therapy can be used. Oral meds have not really been studied in pregnancy. A med called glyburide does not cross the placenta. You want to teach mothers about fetal monitoring, kick counts, having her ultrasounds. Again, these are high-risk women, so they're going to be getting those NSTs or non-stress tests. And you want to teach signs and symptoms of hypoglycemia, just like you would any diabetic. So risk factors, most of the time in pregnancy, risks for everything rise at age 35. For diabetes, it's age 25. So everyone over age 25, you're at risk for gestational diabetes. If you're obese, if you have a history of gestational diabetes or history of a large for gestational age baby, a personal or family history, or history of polycystic ovarian syndrome, those are risk factors for gestational diabetes. So risks afterwards are you're 4 times greater risk of getting preeclampsia, because those high blood sugar levels can damage blood vessels and impair function, which can lead to high maternal blood pressure and impact blood flow to the fetus. You're 4 times greater risk of requiring a C-section. You're at a higher risk of infection, hydramnios, and postpartum hemorrhage. So most of the time, this C-section is because you are having a large baby, and then the risks of infection, postpartum hemorrhage, that's because of the C-section. Hydramnios is a lot of fluid, so if you see hydramnios or polyhydramnios, that's just a lot of fluid inside the amniotic sac. They think that's because of the extra urine from the fetus. So there's risk to mom and there's risk to baby. You need to know risks to both. For Module 1, I would concentrate on our education to mom, risk factors, what do we teach mom? And for Module 2, I would concentrate on, what's a baby of a diabetic mother going to look like? So gestational diabetic risk to fetus, you're 5 times higher risk of perinatal death, 2 to 3 times congenital malformations from the teratogenic effects of hyperglycemia in the first trimester. So too much glucose in the first trimester can actually act as a teratogen. Later, you're at risk of growth abnormalities and sudden uterine death, and macrosomia, dystocia, and hypoglycemia. So macrosomia, big baby, dystocia is getting stuck, and then hypoglycemia is because that baby was getting all that sugar in utero, so it's, all that sugar is going to baby, so baby's making a lot of extra insulin to sort of combat that. Then baby's born, still making the insulin, still producing the insulin, not really getting the glucose supply, so they are at risk of hypoglycemia after birth because they're not getting all that glucose through the placenta anymore. They're not getting that from mom. So those babies are at risk of hypoglycemia once they're born. Again, both mom and baby are at an increased risk of type 2 diabetes later in life. And what you want to know as a nurse is, how you're going to teach mom diet and exercise. They're your first line of defense. You want tight glycemic control, insulin if necessary. You want to teach her how to do fetal kick counts, keep up with her non-stress tests because she is considered high risk now. Most of the time when women are gestational diabetics, or type 2 diabetics, they will schedule birth at term, which is 37 weeks. And then you want your patients to know the signs and symptoms of hypoglycemia as well.